Hello friends. So today I'll be talking about this third update on COVID. So we've already finished first and second update. So this is the third update I'm doing on 20th March 2020 to keep abreast of all the articles that are coming out regarding COVID in the literature. So it's good that we deliberate on these articles so that we are guided appropriately when the crisis arises to manage these patients more effectively. So in this update, I'll be talking about a very important article that came in NEJM, which is the lopinavir and ritonavir study. And the second one, I will be talking about briefly about that ACE and the role of in ACE inhibitors and ACE receptors and its role in coronavirus. And I'll be talking about another small study. So before I start, again I have to reiterate because it's very important. I keep showing this slide to look at where we are poised at this point of time in India and what is the projections that are foreseen in our country. So if you look at this Italian graph, as you see in week 2 there were 152 cases, and week 3 it really increased up to 10 times. So I think this is the enormity of the situation that we are facing, and it may not be long when we are suddenly seeing this sort of an explosion in our country. So it's extremely important for all the academicians to pay attention to these graphs. And if you look at Iran, week 2 they were 43, and week 4 they almost increased up to 40 times, 400 times I would say. So India, if you see, we are on week 2 here, 24, week 3. So as you see, there are question marks here. So this is where we need to really act with a lot more stringent way, with lot more extraordinary decisions that need to be made to curtail our explosion. So I think this is terribly important for all of our academicians to resonate this message far and wide, so that some necessary steps are taken to prevent this catastrophe to happen. I wish to start my talk with this slide because this becomes terribly important at the time where our country is poised and the foreseeing sort of an explosion that could possibly happen from the lessons learned from Italy, Iran, and few other countries. Again, this slide, you would have seen this in some of the WhatsApp groups. So we'll just pay little attention to how this affects. So right now we are in a phase where community transmission may happen. So if a individual comes in contact with 2.5 infected people, and we have to reconcile to the fact healthcare people are at a much higher risk in coming in contact with these 2.5 people, which means to say in 30 days we may have infected 406 people. So that is the precarious situation that healthcare workers may be currently in. And if you reduce this exposure to 1.25, so this is where I am re-emphasizing and reiterating and echoing to all our colleagues that healthcare people also should stop getting in contact with possibly any of the infected patients, because we become potential to spread. So that is the reason I would still urge that all routine elective OPDs should be considered to stop to flatten this curve. Otherwise, we also would be conduits for spreading the infection. So if you half this rate in 30 days, you see the exponential increase in the infected people can significantly be brought down. And if you are in touch with much lesser than that 1.25, you see the community spread can really be curtailed. So this is where our Indian government is also putting extraordinary efforts. We have seen Modi's message to this, alluding to this sort of an effect. So I only hope, pray, and sincerely appeal to everyone who is listening to continue to campaign to mitigate this community spread, because once this community spread happens, scientifically we have to reconcile to the fact that hospitals may not be equipped to handle such a big load in a country like India, because it would be hugely cost prohibitive as well, and there may not be enough beds, and definitely there won't be enough acute care beds with ventilators to deal with this sort of a disaster if we are faced with. So this is something very important. So I thought I should start my talk again highlighting where we are poised and what steps we need to be undertaking. So this is a very small little paper which came as a letter to editor from an Italian group looking at procalcitonin in patients with severe coronavirus 2019, a meta-analysis. It was a small one-page letter to editor. So they did a meta-analysis. These authors did the meta-analysis of 4 studies where they looked at the role of procalcitonin in coronavirus. So what the authors found is when there is an increase in procalcitonin to five-fold. So they picked up all studies where procalcitonin was done in SARS coronavirus. It's not SARS coronavirus 2, which is COVID. So they took all the previous papers because we understand that SARS coronavirus are the same family. So they looked at procalcitonin rise where they looked at this rise in these studies. So what they found is increase in procalcitonin up to five-fold had a higher risk of severe SARS-2. So which means if procalcitonin is high, it may be indicative that the disease manifestation is going to be a lot more severe. And the odds ratio was very high of aligning to the fact that they can have a severe disease. So these are the 4 studies, and if you see all the 4 studies appear to be the Chinese study, and it had a good correlation to say that higher PCT had a good correlation with the severity of infection. And why does this happen in viral? Because our traditional understanding is procalcitonin goes up in bacterial infections, and in viral infections procalcitonin may not be very specific. So this study, if you look at it on the face, it seems to be conveying the contrary. So the reason for that is the authors have discussed in this. So procalcitonin is derived from all the extra thyroid surfaces basically, and then it is released into the circulation, and this release into the circulation from extrathyroidal surfaces predominantly happens in the presence of cytokine storm. And as we have understood, the coronavirus or the COVID-19 creates a cytokine storm. So in the presence of these mediators, interleukin 1 beta, interleukin 6, and specifically there are studies looking at the role of interleukin 6 in COVID-19. So in the presence of these tumor necrosis factor, interleukin 1 beta and interleukin 6, there is release of procalcitonin into the circulation by these extrathyroidal surfaces, extrathyroidal sites basically. And this is usually in viral infections, even when there is a cytokine, this is alleviated by interferon gamma. So what the authors propose is a balance between these two would not lead to rise in procalcitonin, but when there is an imbalance where there is a overwhelming cytokine response and this is not countered adequately by interferon gamma, then you would see procalcitonin rise, and which is typically seen in severe SARS infection. And if you see some of the anecdotal reports, they have even used interferon gamma as a therapeutic modality to COVID-19 or SARS infection, and that is the cellular understanding of the role of interferon. So because interferon gamma is the one which balances out the release of procalcitonin, which gets released because of the presence of these mediators. So that was the gist of this one-page letter to editor that came. So again, you would have seen in WhatsApp, I think this is an evolving situation in the Western countries where you are seeing people struggling to cope with their daily supplies for their regular living. So which is again alarming. Again, to re-emphasize, we are in a much better situation right now in our country. So we need to take more extraordinary steps to prevent all this happening. So this is a very important study which we should deliberate upon. So this came in 18th March 2020, just about 2 days back. This publication came out. A trial of lopinavir and ritonavir in adults hospitalized with severe COVID-19. So this was a open label randomized controlled trial. So the inclusion criteria for this study was any patient who came with COVID-19 with saturation less than 94% or PaO2 by FiO2 less than 300 were included for this study. So they used lopinavir and ritonavir combination twice a day for 14 days. The question should arise, why this combination, isn't it? Why we are using protease inhibitors as a combination for addressing this infection? So the rationale for that is they use 400 mg of lopinavir and 100 mg ritonavir. So ritonavir basically acts as a synergy for lopinavir by it increases the half-life of lopinavir by inhibiting cytochrome P450 enzyme. So it acts it has a synergistic effect in increasing the half-life and enhancing the activity of lopinavir. So that is the reason they have used this as a combination. So the primary endpoint, they looked at duration of clinical improvement. The time taken for good clinical improvement was the primary outcome. And the primary endpoint was to also look at the discharge of the patients, how many survived and how many got discharged. So in the background, why this combination of lopinavir and ritonavir? Because they used this combination in SARS outbreak when it happened in Hong Kong. So this particular experience came from these Hong Kong authors. So in SARS patient, they did a study where they compared lopinavir and ritonavir versus ribavirin to see which is more efficacious, and they found that lopinavir and ritonavir reduced the risk of adverse clinical outcomes in that particular study. And what they found is that it reduced the viral load significantly. Lopinavir and ritonavir, when compared to ribavirin, it reduced the viral load and it reduced the risk of adverse clinical outcome. And similar findings were seen in Middle Eastern respiratory syndrome coronavirus, where they found improved survival, and these are the two studies to allude to that. So this was the background why this study was contemplated, to see if the same effect was seen with the use in COVID-19. So when you see the results, uh, we did have a couple of discussions on this study in couple of webinars we did in the past. So when you read only the abstract and you don't read the full text, on the face value it appears that these drugs were not useful. But when you read the full paper, there is little more clarity that you would gain about possible benefits that it can confer. So I will talk about it. So this was the results. They had 199 patients. 99 patients were in lopinavir ritonavir group and 100 were in standard group. So when they looked at the duration of clinical improvement, hazard ratio in this lopinavir ritonavir was 1.24. That was not statistically significant. And when they looked at 28-day mortality, it was 19.2% versus 25%. That was also not significant when they looked at the overall group. And they looked at the detection of virus as the treatment was going on across various timelines, and they found no difference between lopinavir and ritonavir group, lopinavir ritonavir and the standard group. When they did intention to treat, they looked intention to treat analysis, the clinical improvement was little better in lopinavir and ritonavir because it shortened their duration by 1 day. So that was a positive effect they found when they did intention to treat analysis. And GI adverse events, mainly nausea, vomiting, anorexia, was all more in lopinavir ritonavir group. So this is, when you look at the abstract, this is what you will find. And when you look at the content, main primary endpoint, it appears on face value that it did not have any major benefit in improving the clinical outcome or the time taken for the clinical outcome. Neither does it have a bearing on viral clearance. So this is what you would make out. But if you read the full text, if you go to page 5, if you miss one para, you'll miss out on this essence that comes out. They did find favorable outcome with lopinavir on length of stay. So the length of stay was much lesser in lopinavir ritonavir as compared to the standard group, and that was significant because there was a 5 days difference of reduction in length of stay. And when they looked at day 14 improvement was significantly better in lopinavir and ritonavir as compared to the 45.5% improved on day 14 compared to standard, and that was also significant because there was 15.5% difference in that value. So this is the favorable outcome they found, and this is only, you will get this essence when you read the full text, because obviously this is all not the primary endpoint they looked at. That's why this would be underemphasized. And most important than this is they did a post hoc analysis. This you will only read when you read the full text of this article. So this is the curve on the face value. This is the primary endpoint they looked at, the time duration for the clinical improvement. There was no difference. And this is the viral clearance between the lopinavir, ritonavir and control group. Again, across various timelines, they looked at the viral clearance. As you see, there's no huge difference between these two curves. So mortality in this whole group, as I have been again reiterating in the two previous updates I gave, the COVID mortality when they come to hospital or ICU is in double digit. It's 22.1 here. Even the previous study I said it was more than 20%. So the mortality is not, as 2 to 3% you would hear. When they come to us, it means the mortality is high. When they come to hospital, mortality is in double digit. maybe 11% to 15%. When they come to ICU, it will be more than 20%. So here also mortality is 22.1%. Most important is to pay attention to this post hoc subgroup analysis. So in post hoc subgroup analysis, they took all the patients who were treated within 12 days from the onset of symptoms, which means early treatment. From the onset of symptoms, within 12 days, they took the patient group and they compared the mortality. And if you see the mortality, there was a benefit with lopinavir ritonavir because it was significantly less, 19% as compared to 27.1%. So this is a very important message. Again, goes on to show maybe early initiation, because in the first webinar discussion, I still remember our good friend Dr. Baswaraj was constantly making this remark, maybe early treatment will get. So when I read, in fact, in yesterday's webinar, I said it may not be of much benefit. Maybe there is some benefit when we start early. Maybe there is some subgroup, there may be benefit. Although on the face value, this study is negative, but when we go into the depth or detailing of the patient, I think there is some truth that it may have some benefit. This is what I'm trying to emphasize in this. And accelerated clinical recovery happened in lopinavir ritonavir by 1 day. That we again saw in the main results. And this is also very important. The occurrence of acute kidney injury, secondary infections, need for NIV and mechanical ventilations were fewer in lopinavir ritonavir when treatment was initiated within 12 days after the onset of symptoms. So I thought these messages were significant currently in this disaster where mortality is more than 20%. I think there is some clarity we could gain from the findings, the author. And day 28, when they looked at viral detection, 40.7% were still spreading the virus, which means to say, again, to re-emphasize, when you look at the previous Lancet study, which came on the biggest study in 199 patients, they said the median duration of viral shedding happens from day 17 to more than 20 days. Longest happened up to 37 days. So even here you see the same thing. Even though patients are treated, they continue to be infective. I think that is where we have the problem with this disease. Even at day 28, 40.7% had virus detected, so which is a problem for us. So there are some in vitro studies to look at lopinavir and ritonavir serum concentrations. So they have done the studies with SARS coronavirus, and the effective 50% effective concentration is 4 to 10.7 micromilliliter for lopinavir and ritonavir. For these are in vitro studies to look at the effective concentration. So 50% effective concentration for MERS-CoV was 5 to 7 micrometer. So the conclusions, when you take the primary endpoint which they looked at, lopinavir, ritonavir and compared to standard did not show benefit. But when you look at some specific subpopulation where early treatment was instituted, it seems to have some mortality benefit, some clinical improvement, and the complications also were reduced. So I would leave it to the discretion of clinicians to exercise what they need to do, keeping this information in mind when they are managing COVID-19 patients. So that's about that study. That's all is the truth from the study, how much ever you read, but that's a good essence of that study. Again, this is a WhatsApp forward you would have seen. I think we need to upload the Chinese, the way it appears they have tackled this disease at this point of time from whatever we read from the WhatsApp and other groups. And we see this Chinese army really uploading and respecting the medical professionals. So there is a huge sense of gratitude that is expressed in their forwards that we get, so which is appreciable from our community. So I'll talk about this two-page small article which came in Intensive Care Medicine on 3rd March 2020 to look at the role of angiotensin converting enzyme 2 as a SARS coronavirus 2 receptor, molecular mechanisms and potential therapeutic benefit. So we need to have little clarity as to what this whole correlation between the COVID-19 virus and the ACE2 inhibitors. So what they have found in essence, so the coronavirus or the coronavirus 2 or the COVID virus looks something like this. So it has huge number of spikes. It is almost looks like a satellite. It has lot of spikes, and their ability to adhere to the surface is very high because of these spikes that it manifests. It's a RNA virus, and it has a special affinity to ACE2 receptor. And because of these spikes get adhered to this ACE2 receptors, and ACE2 receptors are expressed on various cells within the lung and in the GI tract. That's why they manifest with the diarrhea. So is what is been postulated. So it binds to the ACE receptors which is present on the cells, and what this does is this leads to internalization of this virus into the cells. So this is how it is acting. So the coronavirus gets adhered, it gets attracted to the ACE2 receptor which is present on the cells, and this virus gets internalized within the cell. And what they have found is this ACE2 receptors, there is an overexpression of these receptors when this infection happens, and there is a hypothesis that there is an overexpression of these receptors in hypertensive patients who take ACE inhibitors. So this is where the whole discussion and debate is happening, whether there is a predilection of these infections to patients who are hypertensive on ACE inhibitors. The reason again being, in the Lancet trial that came on 8th March, I think few days back, in the largest 199 case series, the commonest comorbidity or the higher proportion of patients with comorbidity are hypertensive patients. So that is where the whole debate is. And the mechanism of action is very similar. So, and the Zhou et al. Had shown there is alveolar epithelial cells, AEC, alveolar epithelial cell 2, are heavily present in the lung surfaces. It's present all over the lung surface, and these alveolar epithelial cells express this ACE receptors quite extensively, and that is why there is a adhesion of these virus to these ACE receptors, gets internalized in the alveolar epithelial cells, and all the lung injury that ensues. So another advantage of this is they have proposed treatment with recombinant human ACE2 in some of the studies. Because there is these receptors which are clogged, so you give more of this ACE2, and they have found reduction in interleukin 6 because of presence of this ACE2 which are available freely. So this is at animal level studies. So we need to see whether it translates into any benefit in humans. So that's about that study. So this again a WhatsApp forward, again to re-emphasize, in Norway is imposing fine, significant fine or 15-day jail for breaking coronavirus quarantine. So our Honorable Prime Minister has made an appeal on 22nd of March that we need to have Janata curfew. So I would urge again the listeners to campaign for it, because we are in a very precarious situation and we really need to curtail the social contact and adhere to social distancing to prevent this case cascading to big levels. So I will end my talk with this beautiful video as to what it means when we move to the stage 3, because which means the resource utilization and the manpower burden it would have on managing such patients is something that we cannot imagine with the type of healthcare we would have in our country, is what I would subscribe to. So I would just play this video to see the amount of preparedness one would need when you are dealing with critically unwell patients in ICU. So this is a video from China, and you would see this is a team only dedicated as an intubating team. It's only a team, their whole purpose is only to intubate. They are not doing anything else. And you can see the military level of preparation that they have. Just play this.
从我们开始给病人做插管来说的话，持续提高。
防止对飞沫性溶胶溅到衣服里面，我们暴露的风险最高，我们离死亡的距离最短。也许当你打开口腔的那一刻，它就会有气溶胶啊，有小的这样一些颗粒分子，它就会出来。 正常情况下，我们做拉伸手术的时候，我们只需要穿这样一层隔离衣，戴这样一层手套就可以了。但是现在的随着新冠肺炎这样病人工作操作，需要有3级防护的标准，必须是3层的外套加3层的手套。
包这个
包这个3层的头。
叫什么？羊。因为1月21号做的那个患者做了一个手术，然后3号出现症状，因为那个患者确诊了嘛，手术室的护士长就会通知我，我在家里什么都不能做，只能接受隔离。刚出了隔离期之后，高主任就是也是询问了我的意见，问我愿不愿意继续留在光谷这边。什么都不能做的时候，其实也很难受，因为我的同事他们正在跟这个死神在跑。
带很多可能会让你又会他出汗，所以我现在要保持体力，所以我尽量做的这个不动。
我们马上就要进入ICU的污染区进行气管插管，其中2例病人属于是非常紧急的这样情况。我们的面部其实离病人的这样一个口鼻位置是非常近的，相对于其他的医生来说，我们也是离这个污染源是最近的医生。这种防护是给你所做的面临的危险是相对应的。我们现在的整个气管插管的操作就已经完成了，蓝色的那个现在的话已经到97%了，说明病人就是说他的这样一个氧合得到一些改善。我们分2组，一组的话是白班、夜班，每一班12小时；另外一组备班的话是24小时在内。就是我们就是这样，白班的目的就是要应对有可能出现的各种各样的情况。我们的最高纪录是24小时内插管9例病人。
因为现在值班都是24小时，其实白天还好，晚上的话那时候变化会比较快，然后情况比较急。当你已经睡着了之后，电话突然来的时候，你就会很紧张。我来了 ICU， 然后3床的。好，知道了。
有点胖，有2个很多。
深呼吸来。对，再来。好，再来。好，再来，进来好。
一旦给了药之后，你只有2分钟左右的时间去完成这个动作。
因为在整个插管期间的话，我们病人的宿主回于频尿之后，体内的供氧完全是靠血液中的氧气的这样一些储备，所以对这类病人他的储备非常差，就需要我们在最短的时间内，在不犯错误的情况下完成这样一个操作。我们给的药物起效的话是60到90秒，我们把整个气管插管的操作限定在30秒以内，从病人呼吸停止到最后我们操作完成，2分钟是这么算出来的。我们在3个小时内完成了这样4例的操作，其实还是效率很快的。如果他这类的病人病情突然恶化，或者其他的病区的他的病情，那个病人突然变氧合不好，达到了插管的指征的话，我们还要再次出动。不光是现在这样一个非常的时期，在我们平常的这样一些临床工作中，我们也会经常遇到这样一些重症的病人，甚至就是说很多死亡的这样一些情况。作为一个临床医生来讲，你必须要调整你自己的这样一些情绪，时时刻刻你应该知道你自己的责任是什么。
So thank you very much. I end with this quote. So we need to be very clear in our head as to where we are heading, and we need to head to a situation where we are absolutely in control of our mind, action, and projections. So thank you very much. So I would end my talk here.